Bonjour, rebonjour à tous. Je suis très honoré de présenter le professeur Chami Hassan, qui est professeur de médecine interne, qui travaille dans le département de pneumologie de l'Université américaine de Beyrouth, qui a été enseignant à l'Université de Boston et qui est revenu dans cette jolie ville, qui va nous parler du diagnostic et des actualités thérapeutiques dans les pneumopathies d'hypersensibilité. Ce qui me fait obligatoirement penser, j'ai obligé de dire un petit mot quand même, qui me fait penser au décès du professeur Dalphin, qui était un grand spécialiste des pneumopathies d'hypersensibilité, qui était prévu d'être professeur, qui devait être le président de la Société française de pneumologie, et malheureusement qui nous a quittés précipitamment. Donc merci professeur Chami Hassan pour votre présentation.
Merci, Dr. Soyaz. Switching to English. So I'm going to be presenting to you the most recent guidelines on the diagnosis of hypersensitivity pneumonitis. These were recently published and developed under the auspice of the American Thoracic Society with collaboration with the Latin American ALAT and with the Japanese Respiratory Society. I would like to start by mentioning how challenging it is to diagnose hypersensitivity pneumonitis. The fact is it's a heterogeneous disease, both in the temporal onset, the disease course, the wide range of exposures, the variable radiographic features that interface with the other idiopathic interstitial pneumonias, and the variable morphologic features that are found on biopsies, in addition to the response to treatment. The diagnosis is not straightforward. There's no straightforward diagnostic criteria up until recently, as highlighted by these new guidelines. And there's no serologies or physical features to help, similar to what you see with connective tissue disease associated interstitial pneumonitis, and no high quality evidence for treatment. So HP is defined as an inflammatory or fibrotic disease affecting the lung parenchyma and small airways. And this small airway component is what gives a lot of the feature that we use in the diagnosis. It typically results from an immune-mediated reaction provoked by an overt or occult inhaled antigen in susceptible individual. The guidelines highlight the susceptibility. I mean, every disease, you would consider that people who end up being affected are susceptible, but the sensitization here, I think, is important. And very importantly, that to consider that the inhaled antigen may not be recognized in up to half of the patient, which make the diagnosis quite challenging. So the exposure would be either unidentified or there's a possibility that the process is intrinsic or a primary process. So that's still to be determined. Now, the categorization of hypersensitivity pneumonitis has been historically presented as acute, subacute, or chronic, but these three categories are often not well delineated. And the guideline committee instead used the dichotomy of fibrotic versus non-fibrotic or inflammatory HP because there was a appreciation that the presence of radiographic or histopathologic fibrosis would be the primary determinant of prognosis. So they stuck mostly to fibrotic and non-fibrotic and did not adopt the historical categories of acute, subacute, or chronic. Although fibrotic tend to be more of the chronic indolent presentation and the non-fibrotic as more of the acute. But what was adopted was fibrotic and non-fibrotic because it pertained more to the prognosis. Now, the symptoms and signs of HP include both respiratory symptoms and constitutional symptoms, and the presentation could be acute, developing over days to week, which is most commonly compatible with the non-fibrotic type. Now, these acute presentations tend to occur at hospitals, tend to occur in emergency room. Many of the patients could be misdiagnosed as having pneumonia and may not end up in the interstitial lung disease clinic. It's only when these patients have recurrence or a more protracted illness that they end up being recognized. Now, the more insidious presentation that occurs over months to years is more compatible with the fibrotic type, and more likely to end up in the specialty clinics of interstitial lung disease specialists. So, like I said, patient would be usually susceptible and exposed to an inciting agent, but detecting this inciting agent may be problematic, as these agents are diverse and vary by geographic region. They are primarily proteins coming from microorganisms, fungi, birds, and animals, but they could also be chemicals and polysaccharide. And again, to emphasize that they're not identified in a significant proportion of patients. This slide, you may not be able to see it well, but it just shows you how diverse these agents are. And the same syndrome, for example, that were previously described, say farmer lungs here, could have several agents as the incitings. Okay, it's different fungal proteins, for example, here. The imaging is probably the most important tool to first help us suggest the presence of hypercystic pneumonitis. The guidelines recommend a similar protocol as recommended for the diagnosis of idiopathic pulmonary fibrosis, and they emphasize the importance of getting both an inspiratory and expiratory film. The expiratory film would help us highlight the presence of bronchiolitis and small airway obstruction by highlighting the mosaic pattern. So the challenge again here is that the radiographic feature overlap with other conditions. For example, gram-grass infiltration, which is an important feature in the non-fibrotic type, could be also present in viral infection, could be pulmonary edema. And the combination of ground-glass plus central lobular nodules that's also present in the usually non-fibrotic HP could also be seen in respiratory bronchiolitis. The mosaic attenuation and air trapping could be seen in constrictive bronchiolitis or asthma. And it's well recognized that the fibrotic HP overlap with IPF and the UIP pattern. The guidelines came up with the classification of findings that would be typical for HP, compatible with HP, and indeterminate for HP. And they presented it for both non-fibrotic and fibrotic HP pattern. Now, the key finding here is to have features of both parenchymal infiltration and abnormalities indicative of small airway disease. So features of parenchymal infiltration would be the ground glass or the mosaic attenuation, and the features of small airway disease would be the ill-defined central lobular nodules or the air trapping. The features of that would be compatible with HP usually wouldn't have all these, but there's a specific constellation of findings of lung cyst, airspace consolidation, and subtle ground glass that we'll show you in another slide. These CT scan cuts would show, what the guidelines report for findings of non-fibrotic HP that would be typical for non-fibrotic HP. Under A would be the Santry lobular nodules that would be typical for a non-fibrotic or inflammatory HP. Under B is the mosaic attenuation that you can see here. This is an inspiratory scan, so this is not airway based, while the air trapping would be highlighted here on the expiratory scan. Okay, so if you have features of both parenchymal infiltration and exaggeration of this mosaic pattern on expiratory, which is suggesting air trapping and signaling small airway involvement, this is what we consider features typical of non-fibrotic or inflammatory HP. Now, the non-fibrotic compatible with HP is this pattern that I told you about of uniform and subtle ground glass that you could find on the CT here. I think maybe I could show you with a laser pointer over here, and the non-subtle cysts. For the fibrotic pattern, it's more challenging. Here, you need features of fibrosis, such as reticular findings, together with features of small airway disease. And the guidelines here also categorize the patient as having typical HP or compatible with HP. And with imaging here, you could see findings of fibrosis, such as these increased reticular markings, and here's some traction bronchiectasis, together with features of small airway disease as seen in this mosaic pattern. So once you have this combination of mosaic attenuation together with features of fibrosis, that's considered now to be typical of fibrotic HP pattern. Now, there's other even more challenging findings where we call them compatible with HP. And here you'll have this pattern of upper lung zone fibrosis, which is thought to be very suggestive of HP, but it's rarely seen. So it's less than 10% of HP patients that end up having this pattern of upper lung zone predominant fibrosis. There's another zone of central predominant zone fibrosis that could be compatible, or a combination of fibrosis with ground glass and small airway disease that's given you these mosaic pattern. With regards to the pathology, the findings are also heterogeneous. They're more well-defined for the inflammatory type. It's a traditional triad of an interstitial pneumonia that's bronchiolocentric, so it's surrounding the small airways and resulting in these imaging features. And this continues along the bronchioles to get a cellular chronic bronchiolitis. In addition to that, there's a pattern of fully formed granulomatous inflammation that's also seen on pathology. So once you have this triad, you can have a confident diagnosis of non-fibrotic or cellular HP. Now, the diagnosis of fibrotic HP, similar to the imaging, is more challenging because here you have a chronic interstitial pneumonia that's fibrotic. So you have the fibrosis that's complicating the findings of the cellular HP. And there's two, you could have a UIP-like or an NSIP-like features that could really confuse the picture. But really, what's thought to be the most distinctive finding is the finding the fibrotic lesions in the center of the acinus. We call them centri-acinus fibrotic lesion. Now, to be able to find these, you would really need sampling of multiple sites. So because you could be biopsy one area and you can find findings suggestive of UIP, but maybe if you sample areas that still have some inflammatory ground glass inflammation on imaging, then you would see features more typical of what you would think would be cellular or HP in general. So with this in mind, you can see that the diagnostic criteria would encompass multiple domains, and you would really need a multidisciplinary approach and a multidisciplinary diagnosis to be able to ascertain the diagnosis of HP. So you need the history of exposure to a known offending agent, plus or minus the serum-specific immunoglobulin, or even an inhalation challenge, if this is available, the HRCT patterns that we reviewed, and the histopathologic findings or a BAL lymphocytosis. Now, the guidelines examined the evidence supporting each of these domains. So they looked at whether patients with newly detected interstitial ILD in whom HP is being diagnosed should be subjected to a formal questioning using a questionnaire. And they appreciated the importance of a questionnaire to facilitate the systemic identification of agents that could incite HP, and especially with regards to the local context, as we see that the antigens may differ from one geographic area to the other. However, there was not a validated questionnaire that they found, so they made no recommendation or suggestion for or against use of any specific questionnaire that's been reported in the literature, because they're not validated. The other important question was whether patient with newly detected interstitial lung disease in whom HP is being considered, should they undergo serum testing for immunoglobulins against specific antigen. And with the review of the literature, the test characteristics were found to be really suboptimal, so below 50% both sensitivity and specificity. However, they recognized that the testing would be convenient and adequate for generating supportive data, although there was a clear understanding that a positive serum immunoglobulin would not mean that the exposure is the cause of the lung condition, and the absence of them doesn't mean that the sensitization is not there. There's also lack of standardization of the serum immunoglobulin testing. There's not an internationally accepted HP panel. Each institution has its panel, each area. In Spain, you have different panels than what you have in Mayo Clinic, for example, and so forth. But they emphasize that the importance of development and validation of standard or personalized hypersensitivity panel should be a priority for future clinical investigation. And at the voting, the guideline committee at the end suggested to perform the serum immunoglobulin testing that target potential antigens associated with HP. So this was a suggestion. Now, with regards to undergoing BAL fluid, looking for a lymphocytic cellular BAL, the review of the literature showed that actually there's a higher proportion of BAL fluid lymphocytes in both non-fibrotic and fibrotic HP in comparison to patients with IPF and sarcoidosis. And the difference is about 20 to 30%. So the committee considered that a threshold of 30% lymphocytosis on the BAL would be suggestive of HP. And they've actually suggested to do BAL in patients whose differential diagnosis include fibrotic HP, and recommended BAL for those with inflammatory or non-fibrotic HP. So thinking that this test would be quite useful, especially in the people with the fibrotic test. Of course, the level of evidence was not high in any of those. There was not a single randomized controlled trial looking at diagnosis. Most of these were observational, but the expert recommended doing BAL in non-fibrotic HP and suggested doing it in fibrotic HP. With regards to the issue of doing transbronchial forceps lung biopsy, they found that when the patients, with the review of literature, they found that when the presenting. The study looked at patients with interstitial lung disease. The diagnostic yield of yes.
Le temps est pour ainsi dire terminé pour votre présentation. Si jamais vous pouvez aller à la conclusion, s'il vous plaît, le plus rapidement possible. Merci.
Okay. So for that, they actually suggest doing a transbronchial biopsy for non-fibrotic, and but made no recommendation for fibrotic HP. So for the inflammatory type, the guidelines suggest a transbronchial biopsy, but makes no recommendation when the presentation is fibrotic. For with regards to cryobiopsy, there was two issues. Although the diagnostic yield was high, there was a high risk of complications, and the cryobiopsy was not present in all centers. So they made no recommendation in non-fibrotic HP, but suggested to do actually a cryobiopsy in fibrotic HP. And finally, with regards to surgical lung biopsy, the diagnostic yield is very high, but of course there's a not negligible mortality and and other complication. So they suggest doing a surgical lung biopsy after all alternative diagnostic options have been exhausted. So again, MD diagnosis is very important, and HP should be considered in all patients with fibrotic interstitial lung disease. The challenging diagnosis is, especially when the inciting agent is not identified, and there's also a substantial uncertainty with diagnosing HP in the setting of fibrosis that may look like IPF. And when you look at even when you compare expert MDD, there's quite a bit of variability in the diagnosis of HP from one center to the other, even if you present the same findings to them. Non-fibrotic HP, like I said, is less challenging. The guideline committee came up with diagnostic schemes that integrates all these findings of exposure, whether BAL is done, and whether a biopsy is done.
Professeur Chamy, nous allons vous conclure, s'il vous plaît.
Okay, I'll stop. So in conclusion, sorry, I have to rush through that. Usually in patients with newly detected interstitial lung disease, a careful history should be elicited, looking for environmental factor and exposure. A serum immunoglobulin may be performed to detect the exposure. And for many patients, BAL should be done to look for lymphocyte. If this information accompanied by the HRCT pattern is insufficient, then we should look for pathology after undergoing an MDD with consideration for transbronchial biopsy, cryobiopsy, or surgical lung biopsy. And I'll stop and take questions. Sorry, I was maybe going a bit slow.
Merci beaucoup pour cette belle présentation. Là encore, c'est difficile de parler des pneumopathies d'hypersensibilité en 20 minutes, tellement le sujet est large. Mais merci beaucoup des éclaircissements que vous nous avez apportés. Il y avait une question sur les biopsies, mais vous y avez en grande partie répondu. Nous allons donc pouvoir poursuivre le cycle de la conférence. Merci beaucoup, professeur Chamy.
Okay.
And now it's my pleasure to introduce Dr. Carol Joachim. Dr. Joachim is a pulmonary and allergy specialist. She's the head of the pulmonary department at Mount Lebanon Hospital, Hazmiya, Lebanon, Balamand University Medical Center. After qualifying in medicine from the Lebanese University Faculty of Medical Sciences, she completed her training in Lyon, France, Service du Professeur Jean-François Cordier, Reference Center for Rare Pulmonary Diseases, Competence Center for Pulmonary Hypertension. Dr. Joachim is the former president of the Lebanese Pulmonary Society. Dr. Joachim was invited to speak at several national and international meetings. She's also involved in teaching. Her major field of interest are interstitial lung diseases, especially idiopathic pulmonary fibrosis. Please, Dr. Joachim, the platform is yours.
Thank you, Fida, for the kind introduction. I will be talking about systemic sclerosis, interstitial lung diseases. What is systemic sclerosis? Systemic sclerosis is a rare connective tissue disease that is believed to be triggered in susceptible individuals by environmental agents. Systemic sclerosis is characterized by cellular inflammation, vascular injury, and tissue fibrosis of the skin and multiple internal organs. Cellular inflammation, vascular injury, and tissue fibrosis translate into challenging organ-based complications that define the impact of the disease. The kidneys, esophagus, heart, and lungs are the most frequent target, and the mortality is mostly due to cardiorespiratory manifestations. The involvement of multiple internal organs makes systemic sclerosis a multidisciplinary disease requiring a multidisciplinary approach. And in this study conducted among 4 expert centers in Milan, a multidisciplinary approach allowed early detection and treatment of systemic sclerosis-linked diseases, providing the best care and cure for systemic sclerosis patients. Data on incidence and prevalence are conflicting. Women are more frequently affected than men, with a ratio ranging from 3:1 to 14:1. It usually appears in women aged 30 to 40 years, so very young patients, and an increased susceptibility to systemic sclerosis has been reported among Blacks. Skin involvement is the hallmark of systemic sclerosis. It usually starts with the onset of Raynaud phenomenon. Here you have the 3 phases of Raynaud phenomenon. First, fingers become white due to lack of blood flow, then blue as vessels dilate, and finally red as blood flow returns. Systemic sclerosis has been traditionally classified based on the extent of skin involvement. In diffuse cutaneous systemic sclerosis, there is skin sclerosis proximal to the elbows and knees with an increased frequency of interstitial lung diseases and anti-SCL or anti-topoisomerase 1 antibody. In limited cutaneous systemic sclerosis, skin sclerosis is restricted to the hands, forearms, feet, and face, with an increased frequency of pulmonary hypertension and the presence of anti-centromere antibody. Some patients do not fit into either of these categories and share features with other connective tissue diseases. These have the overlap syndrome. And finally, in systemic sclerosis, sign scleroderma, patients have multiple internal organ disease. They may have interstitial lung disease, but lack skin sclerosis. In 2013, a joint committee of the American College of Rheumatology and the European League Against Rheumatism updated the classification criteria for systemic sclerosis. And in this new classification, lung involvement was added. Why? Because of the increased frequency of lung involvement in patients with systemic sclerosis, either interstitial lung diseases or pulmonary arterial hypertension. Interstitial lung diseases typically occurs early in the course of systemic sclerosis, and pulmonary function test abnormalities are seen within 1 year after the onset of Raynaud phenomenon. These are data from the USTAR database. 65% of the patients had a DLCO less than 80%. 31% of the patients had an FVC less than 80% within 1 year after the onset of Raynaud phenomenon. In this study, 396 patients with systemic sclerosis were followed for up to 15 years. And you can see here in green, then 1 of 2 patients with diffuse cutaneous systemic sclerosis developed pulmonary fibrosis. And in blue, 1 of 4 patients with limited cutaneous systemic sclerosis developed pulmonary fibrosis. So it was clear that pulmonary fibrosis develops in both patients with diffuse and limited cutaneous systemic sclerosis. Since treatment of the renal crisis became possible, the survival of systemic sclerosis has changed, and mortality from the renal crisis significantly dropped from 42% to 6% between 1972 and 2001, whereas mortality from pulmonary fibrosis significantly increased from 6% to 33% between 1972 and 2001. So there is a shift in the cause of mortality in systemic sclerosis, and pulmonary fibrosis is becoming the first cause of death in these patients. Well, you may tell me this is old data. This was 20 years ago. Maybe things have changed. Unfortunately, they haven't changed. These are data from the USTAR database. Pulmonary fibrosis remains the primary cause of death in patients with systemic sclerosis. And this is a very recently published study conducted by Anna Maria Hoffmann-Vold on the impact of ILD in systemic sclerosis. 815 patients with diffuse and limited cutaneous systemic sclerosis were followed with HRCT, and look what she found. Here in red, the presence of any lung fibrosis on HRCT was associated with increased mortality when compared with no lung fibrosis here in green on HRCT. So it was clear that the mere presence of ILD at baseline is associated with higher mortality. Risk factors for the development of ILD include the diffuse cutaneous systemic sclerosis, African American ethnicity, older age at disease onset, shorter disease duration, and the presence of anti-SCL70 or anti-topoisomerase 1 antibody, and or the absence of anti-centromere antibody. However, none of these risk factors is absolute, and I showed you that ILD may develop in patients with limited cutaneous systemic sclerosis and pulmonary hypertension. And there is no correlation between the extent and severity of skin disease and pulmonary parenchymal involvement. Patients with systemic sclerosis usually presents with a dry cough, chronic progressive exertional dyspnea, and bibasilar Velcro-like crackles on physical exam. But respiratory symptoms may not be present in all patients with systemic sclerosis, ILD. This is why high-resolution chest CT is the standard method for the non-invasive diagnosis of systemic sclerosis, ILD, and can detect even mild abnormality. NSIP and bilateral ground glass opacities is the most frequently seen imaging pattern, and a UIP pattern with honeycombing traction bronchiectasis is seen in up to 1/3 of the patients with systemic sclerosis. Over time, the progression is that of the replacement of the NSIP pattern with a UIP fibrotic pattern. This is a 65-year-old woman with systemic sclerosis and bilateral ground glass opacities. 7 years later, same patients developed extensive fibrosis, honeycombing traction bronchiectasis. So it seems as if these ground glass lesions in patients with systemic fibrosis systemic sclerosis are pre-fibrotic lesions in patients with systemic sclerosis, ILD. Pulmonary function tests typically reveal the presence of a restrictive pattern with a decrease in FVC and DLCO, and a rapid decline in FVC and DLCO were identified as markers of poor outcome. Here you can clearly see that the rapid decline of DLCO was associated with a decrease in survival in patients with systemic sclerosis, ILD. Moreover, a decline in FVC and DLCO correlated with the extent of fibrosis on HRCT. A simple staging system, often referred to as the GO criteria, divides systemic sclerosis patients into those with extensive disease and those with limited disease based on the extent of fibrosis on HRCT. In patients with fibrosis less than 10% on HRCT are considered to have limited disease. Patients with more than 30% fibrosis on HRCT are considered to have extensive disease, and in patients in between 10 to 30% fibrosis, excuse me, Patients with an FVC less than 70% predicted to have extensive disease, and patients with an FVC more than 70% predicted to have limited disease. In 2013, a proposed follow-up of patients with systemic sclerosis, ILD, recommended PFTs and HRCT in all patients with systemic sclerosis. If normal, yearly PFTs were recommended, an extensive lung disease treatment was initiated, and limited lung disease PFTs every 3 to 6 months were recommended. If progressive disease treatment was initiated, if stable for 5 years, yearly PFTs were recommended. Last year, in 2019, the European Reference Network on Complex Connective Tissue Diseases published a state-of-the-art on clinical practice guidelines in systemic sclerosis. And look what they found. No clinical practice guidelines were included for ILD. So it was clear that there was an unmet need for specific clinical practice guidelines for the diagnosis and treatment of systemic sclerosis, ILD. This is not the case anymore, with the evidence-based European consensus statement for the management of patients with systemic sclerosis, ILD, published early this year, and I will come back to this later. Treatment of systemic sclerosis is based on organ-specific drugs and should be made on a case-by-case basis. The efficacy of immunosuppressors in systemic sclerosis, ILD, is still a matter of controversy, and until recently, there was no approved disease-modifying treatment for systemic sclerosis, ILD, and I will come back to this later also. Cyclophosphamide was the first studied treatment for systemic sclerosis, ILD. Two randomized placebo-controlled trials, the SLS1 and the FAST trial, evaluated the efficacy and safety of cyclophosphamide in patients with systemic sclerosis, ILD. In the SLS1 study, there was an improvement in FVC with cyclophosphamide after 1 year of treatment, but at the expense of severe adverse events, leukopenia, hematuria, neutropenia, pneumonia, and anemia. Moreover, the effects of cyclophosphamide was lost after 2 years of treatment. This led to study mycophenolate in systemic sclerosis, ILD. In the SLS2 study, patients were randomized to treatment with either cyclophosphamide or mycophenolate, and you can clearly see here no significant between treatment difference in FVC improvement between cyclophosphamide and mycophenolate, but mycophenolate was better tolerated and associated with less toxicity. More recently, there has been interest in rituximab. In a proof of concept studies, rituximab increased significantly FVC and the LCO and was also effective in patients with severe connective tissue disease, ILD, unresponsive to conventional immunosuppression as a rescue therapy with improvement in FVC and the LCO. Finally, the RECITAL trial, a UK multi-center prospective randomized double-blind double-dummy trial, will compare cyclophosphamide and rituximab in patients with severe progressive connective tissue disease, ILD. The study is still recruiting patients and estimated to be completed in November 2021. Then interleukin-6 was found to play a role in systemic sclerosis pathogenesis, and tocilizumab, an anti-IL-6 receptor alpha antibody, was studied in the FASCINATE trial and showed an improvement in FVC in the open label phase of the trial. In the FOCUS trial just published in the Lancet Respiratory Medicine, there was an improvement in FVC in patients randomized to treatment with subcutaneous tocilizumab, here in red, versus placebo. In 2017, came hematopoietic stem cell transplantation, and the EULAR recommended hematopoietic stem cell transplantation only in rapidly progressive disease and in patients at risk of organ failure to be done in qualified centers. Finally, lung transplant is also a reasonable treatment option only in selected patients. So after the results of the SLS2 trial, mycophenolate was proposed as first-line treatment in patients with systemic sclerosis, ILD, followed by cyclophosphamide or rituximab second or third-line treatment, and maintenance treatment with mycophenolate. Until early this year, the first evidence-based European consensus statement for the management of patients with systemic sclerosis, ILD, was published in the Lancet Rheumatology, openly accessible for everyone, and I highly recommend to read this paper. A multidisciplinary expert panel used a modified Delphi process to establish an algorithm for the management of patients with systemic sclerosis, ILD. This consensus agreed to screen all patients with systemic sclerosis for ILD using HRCT or pulmonary function test. This consensus also agreed that nintedanib is an effective treatment for patients with systemic sclerosis, ILD, either alone or in combination with mycophenolate in patients with inadequate treatment response or disease progression. And nintedanib was the first drug approved by the FDA and the European Commission for systemic sclerosis, ILD. Why nintedanib in systemic sclerosis, ILD? Because of the similarity of fibrosis in patients with systemic sclerosis, ILD, and IPF. You all know that fibrosing ILD are believed to be triggered by chronic epithelial damage and abnormal repair. Nintedanib is an intracellular inhibitor of tyrosine kinases that has been approved for treatment for IPF. You all know the IMPULSES trials. In the IMPULSES trials, nintedanib slowed disease progression in patients with IPF. This led to the study the potential of nintedanib in patients with systemic sclerosis, ILD. And this was the rationale behind the census trial, safety and efficacy of nintedanib in systemic sclerosis. The census trial was a randomized, double-blind, placebo-controlled parallel group study conducted in 32 countries. After a screening period of 12 weeks or less, patients were randomized to treatment with either nintedanib 150 milligrams twice daily or placebo. Primary endpoint was assessed at week 52. Key inclusion criteria for the census trial: patient age 18 years and above, with confirmed systemic sclerosis based on the criteria of the American College of Rheumatology and the European League Against Rheumatism, disease onset within 7 years before screening, ILD confirmed based on high resolution chest CT performed within 1 month before screening, and fibrosis affecting at least 10% of the lung. FVC at least 40% predicted, the LCO 30 to 89% predicted. So you can clearly see that inclusion criteria reflected our clinical practice. Permitted medications also reflected our clinical practice. Prednisone was allowed at a dose of up to 10 milligrams per day. Mycophenolate was also allowed, or methotrexate, to reflect clinical practice. Primary endpoint of the study: annual rate of decline in FVC over a 52-week period. Secondary endpoints: absolute changes from baseline in the modified Rodnan score at week 52, and total score of the St. George's Respiratory Questionnaire, Quality of Life Questionnaire at week 52. Baseline characteristics were similar in both groups, nintedanib group and placebo. 53% of the patients had diffuse cutaneous systemic sclerosis. 60% had positive anti-topoisomerase 1 antibody, and 48% of the patients were taking mycophenolate in both groups. Extent of fibrosis on HRTT, 36%, 72% mean predicted FVC in both groups, DLCO, 53% predicted in both groups. These were the disposition of the patients in the census trial. 288 patients assigned to receive nintedanib and 288 patients assigned to receive placebo. Primary endpoint of the trial, there was a reduction in the annual rate of decline in FVC over a 52-week period with nintedanib, 52 ml, when compared with placebo, 93.3 ml. Difference, 41 ml per year, statistically significant. This translates into a relative reduction of 44% in the annual rate of decline in FVC over 1 year. Here you have the absolute change from baseline in FVC, and over time, you can clearly see that at week 12, both curves separated and continue to diverge. So nintedanib clearly reduced the progression of the ILD over time in patients with systemic sclerosis ILD. Here, when you compare the census trial with the impulses trial, relative reduction in the annual rate of decline in FVC, 44% with nintedanib in the census trial, similar to that observed in the impulses 1 and impulses 2 trial, 49% in patients with idiopathic pulmonary fibrosis. The reduction in the annual rate of decline in FVC seen with nintedanib was similar in all pre-specified subgroup analysis. That is, similar in patients whether they had diffuse cutaneous systemic sclerosis or limited cutaneous systemic sclerosis. In patients taking or not mycophenolate, same results. Secondary endpoints, absolute change from baseline in the modified Rodnan skin score or St. George's Respiratory Questionnaire, no difference between nintedanib and placebo. Adverse events, mainly diarrhea and disturbed LFTs were seen with nintedanib, and these are the side effects we are used to see with nintedanib in patients treated for IPF. So in conclusion for the census trial, in the census trial, nintedanib was associated with a reduction in the rate of decline in FVC when compared with placebo over a 1-year period, 44% relative reduction, and no other clinical benefit was observed. Finally, systemic sclerosis is a highly complex disease. The journey of a patient with systemic sclerosis starts far before fibrosis becomes visible, and I think we should work all together, the physician, the patient, and the scientist, to achieve maybe one day the 4P medicine, predictive, preventive, personalized, participatory for our systemic sclerosis patients. With this, I will conclude with my take-home messages. Systemic sclerosis is a rare connective tissue disease with a heterogeneous clinical course. The involvement of multiple internal organs makes systemic sclerosis a multidisciplinary disease requiring a multidisciplinary approach. ILD is a common manifestation of systemic sclerosis and is a leading cause of death. ILD can develop in any patient with systemic sclerosis, even those with pulmonary hypertension, but the risk is increased in those with diffuse cutaneous systemic sclerosis. All patients newly diagnosed with systemic sclerosis should undergo baseline PFTs and high-resolution chest CT to diagnose ILD early, to start treatment early with or without evidence of progression, because I showed you that the mere presence of ILD is associated with higher mortality. And in the census trial, 44% relative reduction in the annual rate of decline in FVC with nintedanib. Nintedanib was, after the results of the census trial, nintedanib was the first drug approved by the FDA and the European Commission for systemic sclerosis, ILD, either alone or in combination with mycophenolate
Dr.
in
Joachim, you have
patients
10
with
seconds.
inadequate treatment response or disease progression. I finished with my recommendation. Always maintain a high level of suspicion. Regularly monitor for ILD in patients with systemic sclerosis, particularly in the first few years after the diagnosis, because today an early diagnosis is possible and is mandatory to start treatment early and improve the prognosis of these patients. Thank you for your attention.
Thank you, Dr. Joachim, for this great presentation on ILD and systemic sclerosis diagnosis, monitoring, and treatment. You have a question from Dr. Fadi Haddad, who is asking you about how can you elaborate more, if you can elaborate more on the fact that after 6 cycles of cyclophosphamide, the beneficial effect will disappear after 2 years.
Okay, this is the study done with the cyclophosphamide. You can see here that after there was an improvement in FVC, and after 2 years, the improvement disappears. We don't know why these patients, after 2 years, cyclophosphamide did not work. This is why they studied mycophenolate as an alternative to cyclophosphamide. Any other question?
Yes, Dr. Haddad is also asking you about any higher risk of infection with combination of mycophenolate, mofetil, and nintedanib?
No, not at all. No side effects at all. And in the census trial, they were given together with no higher risk of infection. Not
Yes.
at all.
Till when we continue TKI and when we are obliged to stop it?
To continue, sorry?
The TKI, I don't know, the tyrosine kinase inhibitor.
The nintedanib.
Yes.
Lifelong, $1 million question. I think we should continue forever the nintedanib as long as we have fibrosis, and we know fibrosis is irreversible. So we have to continue nintedanib lifelong.
Okay, I have a question for you. If you have a HRCT consistent with early fibrotic changes that overlap with UIP, and the patient have worsening symptoms, but you have almost stable full pulmonary function test, do you consider to start nintedanib?
Of course, I will start nintedanib first because the patient is symptomatic, he has symptoms, and because on HRCT we have fibrosis, so we should start treatment as early as possible. We don't look at the PFTs because PFTs may be normal when we have, even if we have fibrosis on HRCT. So the patient is symptomatic, HRCT, fibrosis, we start treatment immediately. Because as I showed you, there is increased risk of mortality when disease will progress.
Okay, thank you, Dr. Joachim, for this kind presentation.
Bonjour, rebonjour à tous. Je suis très heureux de vous présenter et d'introduire le professeur Gian Fares, qui a été directrice du Centre des pathologies interstitielles et des maladies rares pulmonaires du Centre hospitalier universitaire de Cleveland, qui est revenu à Beyrouth pour travailler sur ces thématiques-là à l'université américaine. Et dans le cadre des pathologies rares, va nous parler de la lymphangiomyomatose. Professor Fares, the floor is yours.
Thank you. Okay, so I'm very happy to be here today. I was actually at the American University of Beirut when I agreed to do this talk, but unfortunately, or fortunately, I'm back in Cleveland now. So I'm back to Case Western Reserve University, University Hospitals, Cleveland Medical Center. Today, I will be talking on an update on the diagnosis and management of lymphangiomyomatosis. The objectives of the talk, we will briefly overview the presentation of LAM. I will highlight the new diagnostic guidelines and the management options. We will start with a case. This is a case of a 50-year-old African-American female that I saw in my clinic when I was still in training. She was referred for abnormal imaging that was done as a pre-op workup for shoulder surgery. She complained of dyspnea on exertion, but no other systemic symptoms, did not have any significant medical or family history. She was using occasionally albuterol, and in terms of exposures, not much, and she was a very mild smoker. So her X-ray, as you can see, show increased interstitial marking and maybe some hyperlucency in the upper lobes. On her chest CT, I'm highlighting here on the sagittal view that there is involvement of the upper lobe, the middle, and the lower lung zone by a diffuse cystic process. And because we are mostly used to look at axial images, these are her axial images. There is a diffuse cystic process. These are cysts that are round and thin wall, and they are affecting the upper lobes, the middle lobes, and the lower lobes. So I am gonna give you a question here to think about. Unfortunately, I don't know how to pull the audience, but just to think about what would be the best next diagnostic step in this case. It's either that the CT findings are characteristic of LAM and no further workup is needed. One can obtain an abdominal CT to look for angiomyolipomas, or we can obtain a VEGF-A level, a VEGF-D level. One can suggest a transbronchial biopsy or a video-assisted surgical biopsy. So let's go over some LAM quick facts. So LAM is rare. It's actually very rare. It's a very rare multi-system disorder. It was most recently classified as belonging to the family of neoplasms with perivascular epithelioid differentiation. We know that LAM is due in part to mutation in the tuberous sclerosis 1 or tuberous sclerosis 2 gene. This in part leads to an unregulated mechanistic target of rapamycin pathway, and which is responsible for cell growth and survival, which in turn leads to an abnormal proliferation of smooth muscle-like cells, which are the LAM cells, which can migrate to the lung or can migrate to the kidney. More quick facts about LAM. LAM, like we said, is rare. And to put it in comparison to other ILDs, for example, the incidence of LAM is 3 to 5 per million, while the incidence of IPF is 13 to 20 per 100,000. The incidence of sarcoidosis is 10 to 80 per 100,000 African-American, or 8 to 100,000 per Caucasian. Compared to pulmonary alveolar proteinosis, pulmonary alveolar proteinosis is also very rare, and it's 7 per million. In terms of gender, when I was the fellow, we used to say that LAM is exclusively seen in women, but now we changed the wording to say almost exclusively, just because there are case reports of LAM in men in the setting of tuberous sclerosis complex, but there is maybe one case report of a male with LAM. The average age at diagnosis is 35 years, but LAM has been reported in teenagers and postmenopausal. And there are two big forms of LAM. There is the LAM that's associated with TSC and the sporadic form. So when we think about the LAM that's associated with TSC, there will be other, obviously, manifestation. It involves, there are problems with the brain, the eyes, the skin, there are facial angiofibroma, kidney problems, and TSC is an autosomal dominant disease, and 30% of the patients with TSC will go on to develop LAM. LAM in the setting of sporadic LAM, obviously it is a somatic mutation and it lacks all the features of the tuberous sclerosis complex. So what about the clinical manifestations of LAM? So there are, like we said, LAM is multi-system, so there will be lung involvement, lung and pleura, and outside the lung. In terms of lung involvement, the most common presentation of LAM is shortness of breath with exertion and fatigue. Another very common presentation is pneumothorax. Pneumothorax is very common in LAM. It's about 2/3 of the patient will develop a pneumothorax, and it's the initial presentation in about 36% of the patients. And the problem with pneumothorax, it is actually often recurrent. Another pleural disease with LAM is chylothoraces. So chylothoraces are not as common as pneumothoraces. They're seen in about 10 to 30% of patients. They are unilateral, mostly on the right side. Chylothoraces are milky fluid. They have a high level of triglyceride. And they rarely also, people with LAM will have chylous ascites and chyluria. In terms of outside the lung, about 30% of patients with sporadic LAM and maybe about 80% or more of patients with TSC LAM will develop angiomyolipoma, angio for vessel, myo for muscles, and lipoma for fat. And these are benign kidney tumors. So when it comes to the workup of LAM, the patient will come to be suspicious to have LAM based on imaging most of the time. And further workup will need to be done. We will be, of course, conducting PFTs. PFTs can be normal, or most of the time will show obstructive lung disease. About 30% of patients will have a positive bronchodilator response. Less commonly, it can show restrictive lung disease. We do have a diagnostic marker for LAM, a laboratory diagnostic marker, VEGF-D, which I will go into more details about it in a little bit. And there is, of course, pathology. There are specific pathologic findings characteristic of LAM. So the guidelines for the diagnosis of LAM, there are two major guidelines. There is the European Respiratory Society guideline that was put out in 2010. And there is the ATS, the American Thoracic Society, and Japanese Respiratory Society guideline that were put out back-to-back in 2016 and 2017, addressing several and different problem with the disease. So the ERS in 2010 wanted us to think about LAM into indefinite LAM, probable LAM, and possible LAM. To be able to diagnose definite LAM, we have to have characteristic HRCT findings. And by that, they mean you have to have more than 10 cysts, and they have to be thin wall, round, uniformly distributed, or it can be compatible HRCT when you have between 2 and 10 cysts, and a lung biopsy that fit the diagnosis of LAM. If you don't have a lung biopsy, but you still have characteristic HRCT findings and the presence of angiomyolipoma of the kidney, thoracic or abdominal chylous effusion, lymphangioliomyoma, or a lymph node involved by LAM, or if you have definite or probable TSC, then you did not need the biopsy and you can have definite LAM. If you have characteristic and compatible clinical history alone, then they will call it probable LAM. And if you have compatible, so less amount of cyst and other findings, you will call it also probable LAM. So how does the ATS guideline differ from the ERS? Not very much. They want us to be able to definitely diagnose LAM if we have the same thing, if we have characteristic HRCT findings. In the absence of biopsy, you have to have one of the same findings that the ERS talked about, meaning if you have TSC, renal angiomyolipoma, chylous effusion, and the other findings. The only difference is that the ATS guideline added the serum VEGF-D level in their diagnostic criteria. So for example, if we go back to our case, this is the lady, she has a lot of cysts. This is pretty advanced LAM. They're round, they're thin-walled, they're uniform, and they are diffuse. Before proceeding to a biopsy, we would have maybe ordered an abdominal CT to look for angiomyolipoma or a VEGF-D level, but at the time, VEGF-D was not even in the criteria. So luckily for us, she ended up actually having an angiomyolipoma on her kidney, and with the new guideline, this would have been enough to say this lady has a sporadic form of LAM. If I give you, for example, another case who has, this is another patient we follow, she has much less numbers of cysts,
they are maybe less than 10, but she has TSC. So in this case, we don't need a biopsy. We don't need further diagnostic testing. This is also diagnostic of LAM. So how about VEGF-D? So how did VEGF-D came to life? So VEGF, vascular endothelial growth factor, there are 4 of them. There is A, B, C, and D. So A and B are mostly angiogenic, while C and D are mostly lymphangiogenic. So they do promote the growth of lymphatic, but they also promote the spread of tumors to lymph node in mouse model and human. So somebody had the idea, since we figured out that LAM, it's a problem with lymphatic, that why don't we check a VEGF-D and C level for that matter in patients with LAM and compare them to healthy control. So when they did that, they found that in patients with LAM, they have a much higher level of VEGF-D, but not C, compared to control. So then a year or two later, the Cincinnati group, Dr. McCormick is the scientific leader of the LAM Foundation, and he's like a big name in LAM. So they published a correspondence to the New England Journal of Medicine when they checked their patients who have sporadic LAM and compared them to healthy control, but also to other cystic lung disease. For example, in this slide, I put a picture of a cystic lung disease in LAM. This is a PLCH. The cyst will be more like bizarrely shaped, or a picture of emphysema. And when they compared these findings, they found that cystic LAM has a much higher VEGF-D level compared not only to healthy control, but also to other cystic lung disease. The only issue in the correspondence that in the PLCH and emphysema, there was only like a few patients. So they followed it up with another study. And in this study, they looked prospectively at people with cystic lung disease that were not, did not meet definite criteria for LAM. And they also looked at their database retrospectively and compared people who ended up having a definite diagnosis of LAM versus other cystic lung disease. And in the cohort, there was emphysema, PLCH, Birt-Hogg-Dubé, and Sjogren syndrome. And they found that compared to other cystic lung disease, lone LAM, they called it lone LAM just because this is sporadic LAM with no other manifestation other than the cyst. They found that a VEGF-D level that's much higher, and they found that a cutoff of 800 picogram per milliliter, 800 picogram per milliliter would be a good cutoff with a good sensitivity and specificity for the diagnosis of LAM. The problem with there are some limitation with VEGF-D because although it doesn't have a false positive rate, there is a false negative rate. About 25% to 30% of patients with LAM confirmed otherwise would have a normal VEGF-D level. The usefulness of VEGF-D in women without the cyst is unknown. In the US, at least, the test is not widely commercially available, meaning you cannot just order it to any big specialty lab. It is only commercially available at the Cincinnati Children's Hospital. And sometimes there is confusion what people order. They might order a VEGF-A level, which is a marker for other malignancies, rather than the VEGF-D level, which is the marker of LAM. So if a patient ends up having a biopsy, and what does the biopsy show? It shows cystic lung disease. This is a biopsy from my first patient that I showed you. It showed these on high power magnification, those spindle cells, they are the LAM cells. And this is a board questions for the fellows. LAM cells react with HMB45, which is actually a melanocyte marker. So based on all of this, the ATS put out for us an algorithm for a systemic and stepwise approach to how to diagnose LAM. So first of all, if you have a clinical suspicion with an HRCT feature, a characteristic of LAM, your next step will be to look for TSC because the findings can be subtle. And if you don't find PSC, then we are now thinking about sporadic LAM. We can order a serum VEGF-D level, look for angiomyolipoma in the kidney, or for other diagnostic criteria. And if we find any of these, then we have a confirmed diagnosis of LAM. If we don't, then the next step would be to have a biopsy. And the ATS recommends to proceed with a transbronchial biopsy because the diagnostic yield in different studies was about 50%, and some of them was about 70%. So a transbronchial biopsy would be less invasive. And if no diagnosis was made, then we can resort to a surgical lung biopsy. So what's the prognosis and natural history of LAM? In terms of the prognosis of LAM, this is actually the registry, the NHLBI LAM registry, that they looked at about 217 patients with LAM between 1998, enrolled in the registry between 1998 and 2001. And they found that the FEV1 decline in patients with LAM, this is kind of natural history, no treatment, is about 90 milliliter per year. So if we think a normal healthy person drops about 25 to 30 per year, that's about 3 times the rate. And when they looked at the median survival in this untreated cohort of patients, they found that about the median survival, meaning like more than 50% of the patients are alive after 20 years from diagnosis. This is obviously a great news for LAM patients because some literature was suggesting that the median survival is much less than that.
Professeur Fares, il reste 2 minutes, s'il vous plaît. Je suis désolé.
Okay, very good. I'll do it quickly. So in terms of treatment for LAM, there are supportive measures and pharmacotherapy. So in terms of treatment, so the only FDA-approved medication is sirolimus, which is an mTOR inhibitor. Sirolimus came to light based on the MILES trial. This is now 2011, done by McCormick. They did 2-year treatment phase for 1 year, observation phase for 1 year, and they found that sirolimus will stabilize your lung function. But when you stop the medication, it's not a curative medication, the decline will pick back up. So sirolimus is approved for people who have an FEV1 less than 70, or people with a declining pulmonary function test. It's also approved for symptomatic chylothoraces. The dose of sirolimus, the favored dose is the low dose, targeting a blood level of 5. So I will just skip that one. Some side effects of sirolimus are acne, oral ulcers, and high cholesterol. A dreaded complication is pneumonitis. It's very rare though. It was not seen in the MILES study. I will skip this one too. And for refractory disease, you can either up the sirolimus dose to target like a higher serum level, or people can be referred for lung transplant. The median survival of LAM after lung transplant is about 12 years, which in this graph is telling us it's much better than what it is for other lung diseases that get transplanted. The number of patients in the US that are transplanted for LAM are about between some 10 to 12 a year. If I have 1 more minute, I will just talk about maybe the pneumothorax. So it's recommended that after the first pneumothorax, that patients undergo a pleurodesis procedure. And the preferred procedure is actually VATS-guided abrasion. If this fails, then they can go ahead and undergo talc pleurodesis. And prior pleurodesis is not a contraindication for lung transplant. It might increase some risk of bleeding, but does not affect the ultimate outcome in terms of mortality or length of stay. Do I still have time?
Merci.
So air travel, there is a risk of pneumothorax in terms when patients travel, about 1 to 2% per flight. So, I mean, we don't discourage them from traveling unless they have very, very bad advanced cystic lung disease. And if they have an active pneumo, they cannot travel, of course. If they recovered from a pneumo, then they should wait like 4 weeks to 6 weeks before they can travel. In terms of pregnancy, it will always be a personal decision, but pregnancy will accelerate the decline in lung function, increase the risk of pneumo and chylothorax.
Il va nous falloir conclure maintenant. Je suis désolé de vous ennuyer.
No problem. Okay, I'm done anyway. Okay. If there is time for some questions, I'd be happy to take some questions. If not,
Eh bien, écoutez, non, il n'y a pas de questions pour cette très belle présentation néanmoins. Bonne séjour à Cleveland et merci pour cette très belle présentation. Merci beaucoup.
Yeah, I meant I meant fortunately I left AUB. Unfortunately, I left AUB, but fortunately I left Lebanon. I just want to be clear.
Merci beaucoup. Au revoir, madame.
Okay, and now we'll move to Acte Lyon Symposium, and it's my pleasure to introduce Dr. Imad Bouakel. Dr. Bouakel is an associate professor of pulmonary and critical care medicine at the American University of Beirut. He currently runs the pulmonary hypertension and CETF group at the university. The group started recently performing pulmonary endarterectomy at the medical centers. He also chaired the critical care committee and is the director of the pulmonary fellowship program. Dr. Bouakel has multiple research projects and publications on pulmonary arterial hypertension and pulmonary veno-occlusive disease genetic changes in Lebanon. He also has multiple research publications in medical education and critical care medicine, and more recently, COVID-19. Dr. Bouakel will present triple therapy in PAH, time is critical, intensify. Please, Dr. Bouakel, the platform is yours.
Thank you. Thank you for this presentation, and thank you for being invited for this very nice conference. Well, I'll start with the topic. As you can see, triple therapy in PAH, intensify. Intensify, it seems like, ooh, we have to be very aggressive. And so it was a good opportunity for me to look at the literature and see how to try to reflect the importance of moving up with therapy. So before starting about therapy in PAH, I would like to remind everyone that in 2019, in the PAH symposium, there was a change in the definition of PAH. The new normal is up to 20, so 21 is considered at this stage to be, to have the pulmonary arterial hypertension disease. And obviously the new definition is pulmonary arterial pressure of more than 20, a wedge of 15 or less, and a PVR of 3 Woods unit. The borderline level of 20 to 24 obviously pose a unique challenge. It poses a unique challenge because it's a new added population, and although we know they have a higher mortality in the general population, it is not clear if treating it will change it. Only 1/4 of patients with PAH in scleroderma will develop eventually if they have 20 to 24, meaning in this subcategory, they will develop eventually pulmonary arterial hypertension, and that's eventually, but after 1 year. So it may take longer to develop or maybe never. The PVR limit was not changed in parallel to the pulmonary artery pressure. So some argued that maybe 2 would correspond better to a pressure more than 20. And so now we have this as a change, and obviously studies will try and will be adjusted to take this into account. So now this is a new definition, and there are still questions to be asked. For example, should we treat a patient with a mean pulmonary artery pressure of 22? Should we start therapy? Well, obviously the panel looked at this, and their answer was, as I'll read it as is, that the hemodynamic inclusion criteria in the majority of patients were as follow: pulmonary artery pressure wedge less than 15, mean pulmonary artery pressure more than 25, and pulmonary vascular more than 3. So in this, so all the studies, all the controlled, randomized controlled studies were done with the above definition, meaning with the 25 as the number to define pulmonary arterial hypertension. So it is not clear if the efficacy and safety ratio of the treatments that I'm going to describe or that is recommended apply to this subcategory. So I guess you have to wait and see. Now, I'm not going to say fortunately, but I'm going to say that at least at this stage, and especially in Lebanon, I doubt we're catching a lot of patients in this category. It maybe in rare cases of scleroderma, where we do close and follow-up screening for PAH, maybe we can catch them in subcategory. But as we all know, all of our patients, or most of them, are diagnosed after symptoms, and to have symptoms, you're really beyond 25. Now, obviously, the classification did not change. It's still the same. We have 5 categories, and today I'm going to talk about the pulmonary arterial hypertension part, which is type 1. The idiopathic, heritable drug toxins, the associated with connective tissue disease, HIV, portal hypertension, congenital heart disease, etc., as you can see on the left side of the slide. I'm not going to go in details about classification. It's not the purpose of our talk. Now, this is the ESC ERS guidelines, which provide a clear but complicated evidence-based diagnostic algorithm. But, to simplify it, I would say mainly, you suspect PH, you see it on echo, rule out major causes, lung and heart, and then move into subcategorization with a VQ scan and refer to a PH center for a right heart cath and further testing. Now, before I talk about the importance of therapy and the importance about escalating therapy early on, let's remind ourselves about the seriousness of this disease. PAH, meaning type 1 pulmonary arterial hypertension, is really a lethal disease. And as you can see, a PAH patient who is functional class of 4 has a 5-year survival around 27%. That's really worse than many cancers. Obviously, the lung and bronchus cancer survival hopefully has improved a little with the introduction of new drugs. This data for cancer is from 2010, but still from the standpoint of PAH, it's a recent data and it reflects the severity. Even functional class 1, meaning almost no symptoms, they still have a survival of 5 years of 88. Meaning when silent, still it can kill because it can progress initially silently. And you can see the other green bars for functional class of 2 and 3. So how do we treat PAH? We know that there are general measures that we implement. I'm not going to talk about them. I'll talk mainly about the targeted therapy. The main treatment are 3 main classes of medications targeting the 3 pathways involved in PAH. We have the prostacyclins, the endothelin receptor antagonists, and the phosphodiesterase 5 inhibitors. In Lebanon, what we have, it's obviously limited to what we have, the treatment that we choose. We have Selexipag, which is not really a prostacyclin, but it's an oral prostacyclin receptor agonist. So it acts like a prostacyclin, so I left it within that pathway. The endothelin receptor antagonists that we have are bosentan and macitentan, and the phosphodiesterase inhibitors, sildenafil and tadalafil. All of them have been investigated. Now, the treatment algorithm that is proposed is to start mainly to look at the patients, do the vasoreactive testing. This is the first step once you confirm your diagnosis with the right heart cath and in a center that can do the vasoreactive test in nitric oxide, you do your vasoreactive testing. If positive, you start the patient on calcium channel blocker, and depending on response, you either continue it and escalate therapy, or you move back to the usual non-vasoreactive population treatment. And here, when you start, it is very important to assess where your patient is, what we call a risk assessment. And risk assessment is very important in PAH because we cannot wait for symptoms to appear, and we cannot only treat clinical symptoms of the patient. And we identify patients as low or intermediate risk or high risk. Now, for the low or intermediate risk, the current approach is initial oral, double oral, with few exceptions we'll talk about single monotherapy. Now, for high risk, it should include IV prostacyclin, which we do not have at the current stage in Lebanon, but hopefully we will be able to get, and combination therapy as a possibility, and I'll talk about it later. Then obviously close reassessment of what? Mainly the risk status of the patient to adjust your treatment up. and never down. So for monotherapy, those are the proposed treatment in the guidelines in the European cardiac and pulmonary respiratory societies, and they include the following in all classes. Obviously, you have the ambrisentan, bosentan, macitentan, sildenafil, tadalafil, riosigwat, and at the end, at the bottom of the list is selexipag, which is the prostacyclin receptor agonist. So you can start any of them in both functional class 2 and 3. None is recommended in functional class 4 because it's only the IV form. And there is good evidence behind the treatment. Now, more commonly, it's the double therapy. It's a long list, but I just, highlighted the ones that received a level 1 recommendation. And they are macitentan with sildenafil, riosigwat with bosentan, selexipag added to ERA or sildenafil, and sildenafil added to epoprostenol. Those have been studied. Now, more recently, other studies have shown this is at 215. So you have also ambrisentan and macitentan combination that you can start. It is not in the recommendation, but we know that there are evidence that they have good response as initial double therapy. Now, the rationale of treatment is very important, and a lot of questions has been there and have been asked and answered partially, obviously, with the appearance of new studies. And these questions I always asked myself when I practiced pulmonary arterial hypertension since I started really focusing on the topic in the 2014. So the current practice is sequential triple therapy, where you, or at the time it was, where you start with monotherapy at the baseline and then move to double therapy depending on your risk score, and then you move up into triple therapy. And the questions comes, when should we escalate care? And what happens if we, we wait longer? Eventually, we can always add a treatment and see if the patient will improve. So we can add a second or third. If we're a little bit late, what's the end? How aggressive should we be? And should we, and if you read the literature, especially review articles or editorial, you can see that there is a lot of discussion that why shouldn't we start with triple therapy, upfront triple therapy, maybe the patients will do better. Now, there are no randomized control study comparing upfront triple with sequential escalation of care. So obviously when triple is compared to double, patients do worse, but what if you add the medication later on? Would the patient catch up? Those are, reasonable questions, especially that the medications are very, very expensive. All of them have their own side effect. So to move up, it has to be worth it. So before I talk about how to move up, I want to mention what we mean about risk assessment. So there are two types of risk assessment that are out there. There are more types, obviously. A lot of countries have proposed their own risk assessment based on their own registries. But the two main ones now, or the most commonly used and that I use, are the one based on the guidelines of the European ECS and ERS, ESC and ERS guidelines from 2015 that covers this three color, green, yellow, and red, going over multiple variables, like mainly functional status, symptoms, 6-minute walk, cardiac exercise testing, cardiopulmonary exercise testing, pro-BNP or BNP, and heart finding and hemodynamics in a right heart cath when you're in doubt. And they expect a close follow-up of 3 to 6 months, where you should push the patient, always keep him in the low risk category, in the green, maybe allowing 1 yellow, but not more than that. And once you see that he has moved 1 step up, you push him down, and the risk of death at this stage is 5%. In the yellow is 5 to 10, and more than 10% in the red. Now, the other one is the reveal, where you enter the data and you have numbers. And I just, for the audience, because the first time I saw reveal, it was a little bit for me kind of counterintuitive. So how do we interpret the findings? Okay, so you have WHO group, get +1, +2. You can get a minus if you're doing well. So the number is minus, but you have to keep in mind that at the bottom, you can see that whatever you get as a sum, you're going to add 6. And this is how you can get a 0, because you have minus in green. If all is minus with a 6, the score can be 0. But what does the score mean? And this is a graph that really quantify the predicted 1-year survival depending on your score. And you can see that a score of 7 or less, you have a good survival and you're a low risk. If you have a score of 7 to 9, you're in the average, and your mortality now is around 90%. Survival is 90%. And if you're above 11, that's a very high risk of mortality. So what you want is you want to keep your patient in the 7 or below, maybe 8 level. Sometimes you can, but this is what you should try and keep the patient. And it's a nice calculator available on the internet that you can use. So this is, at the larger size, I guess, if you want to read it or read it later, as assessment of risk. And you have to use these. You cannot rely only on symptoms. So upfront triple combination therapy, big push for it, started with a small study done mainly triple therapy with IV epoprostenol in patients with functional status 3 or above. They had severe hemodynamics. As you can see, the cardiac index was low. So this is a very high risk population, high risk of mortality. The mean age was 39 in this population. And they followed them over time. And you can see that they had an improvement over the next 6 months. In the 6-minute walk, they had improvement in the mean pulmonary arterial pressure. Impressive, even if without a comparative arm. But the more even telling part is that in this upfront triple combination in severe PAH, what you have is that the overall survival was 100, 100, 100 at 1 to 3 years compared to the transplant-free survival estimates that was at the time 75, 60, and 49%. So obviously, compared to a general estimate based on other studies, they had remarkable response with triple therapy. So this was the first signal that early treatment is important. You have to stay ahead of the disease. And this is an example where when started, all 3 people did well. Now, how about the impact of delayed therapy? We don't have a comparison between starting double and then increasing, but I found this meta-analysis with interesting results, because this is a meta-analysis that included 6 data sets of PAH therapies with randomized controlled trials. And what they did is they followed the open label extension where patients were randomized into control versus treatment. So the control did not get treatment for 12 to 16 weeks, because the study was 12, 16, these studies, 12. And then they were given the treatment, because at the end, the study showed the treatment is good. So the ex-placebo received the same therapy as the treatment arm, however, after 12 or 16 weeks. So what happened to these? If you follow them, you notice that what happened is, those are the studies, breathe 1 areas, and they were randomizing bosentan, abrisentan, riociguat, tadalafil, treprostinil, so all classes with control. So it doesn't matter what class of treatment, any. So what happened to these patients? These patients, after 12 to 16 weeks delay in starting therapy because they were the control arm, when they started the treatment, they had improved in the 6-minute walk, but they never catched up to the patients that received the treatment from the beginning. So this short-term delay, only 12 to 16 weeks, depending on the study, had adverse functional, outcome on the functional capacity, and they never were able to catch up. Obviously, these studies were not designed for mortality, but we know patients that have poorer functional status, they have worse survival. So this is the treatment algorithm. And so we're going to now talk about the triple sequential. So 1 to escalate therapy. Obviously, a delay has severe consequences. So the triple therapy, obviously, we have to talk about the third drug, which is selexipag, which is the oral prostacyclin agonist. I have to talk about the Griffon study. It's really a large study, included 1,100 patients. It randomized into placebo and selexipag. And in the placebo group, we had patients that were on double therapy, single therapy, or nothing. double therapy and was 33% of the population, and they were randomized. And they looked at mortality, morbidity. The definition of that is disease progression, hospitalization, worsening PAH, and all-cause mortality. So I want to look at the adding selexipag to the double combination. This is in subgroup of patients, which is 376 patients that was in this study. And a small group was a functional status 2, and another was functional status 3. And a post hoc analysis of these patients will shed light on the efficacy. We can see that the patient improved significantly when they received the treatment, functional status 2 in both classes. When they added selexipag to the other two medications, the overall was 37% improvement. However, if you started early, the improvement, and this is mortality morbidity, in functional status 2 was 64% reduction. So obviously, if you start early, the benefit of mortality is more significant, although this is not a direct effect, it's an indirect, observation that starting early will impact mortality more than starting late. In the functional status 3, only had 26% reduction in mortality, so better start early. Now, the primary composite point for mortality morbidity for all groups was positive, and there was a risk reduction of 40% of morbidity mortality. If you want to look at the, at the details, we can see that it is almost the same like the morbidity mortality. So we can say that the addition of a third drug early on will have significant improvement, although some patients had to stop the drug because of side effect. As you know, 3 drugs that have the same effect, you can feel the side effect more, mainly is headaches. This is a list of the side effect, and headache is top at the list when you compare it between the placebo and the selexipag group. All 3 drugs will cause headache due to the vasodilation. Now, this is an expert opinion, an expert clinical consensus. They looked at it, and they had some recommendation if you're interested to look at it. I'm not going to go into detail, but mainly if you're functional class 3 or functional class 2 with any of the hemodynamic effect that put you at the risk, then you should start him on the third drug, similar to the risk assessment that I presented. This is a, kind of like a table. You can take a look at it later, but it is within the same realm as the general assessment that I talked about at the beginning. So change in paradigm, initial combination, move up rapidly, or initial monotherapy in rare cases, those rare cases that you discover maybe by chance early on. So what is the take-home message? I think first is you make sure you have the right diagnosis, because otherwise you will have problems, especially if you have other types of pulmonary arterial hypertension. Second, start your therapy early with double combination with very few exceptions. And you have to know and frequently do your risk assessment and use the tools to do that, to escalate care as early as possible. Just remember that a delay of just 12 to 16 weeks of treatment has long-term consequence on function, and very likely, as I said, it's indirect evidence on mortality, morbidity. Thank you.
For this kind presentation, we have no questions for this session. Thank you.
Wow, thank you. Okay, so now I'm going to talk about another topic, which is, it's not a presentation about the disease, but rather I would like to share with the Pulmonary Society members and the audience that is with us today interested in pulmonary, that during the next year and early on during the next couple months, we're going to launch, the Lebanese Pulmonary Society is going to launch multiple registries. So I'm going to talk about them in general, and then of course the detail will be sent to you. So what are we planning to do? Actually, we're going to do 4 registries created in collaboration with Science Pro who will provide the technical support. We have a PAH registry, pulmonary arterial hypertension, mainly type 1 and type 4. Of course, during this 10 minutes, I'm not going to go in details into in the inclusion and exclusion criteria. We have a registry on interstitial lung disease. We'll have a registry on cystic fibrosis and severe asthma. This will be the first 4 registries. Hopefully, if successful, we're going to launch even more registries. Why? Before the why, the registries will take the form of a limited data set. What does that mean? It means that all data entered into the registries will be anonymized, meaning there will be no identifiers to link the data of the patient in the registry to the patient. Okay? So as such, no informed consent will be needed from the patient. And because we cannot know who the patient is. This is a form that is used in multiple places internationally, and we're going to adopt this form. Institutions or individuals, of course, mainly physicians, will sign a data use agreement. And this agreement that you will look into detail is meant to protect the patient's privacy, and it is meant to protect and govern the use of the data that will be sent to LPS. The inclusion and exclusion criteria are disease specific, obviously, and the list will be sent to you by email soon, along with the rules and regulations of the registries that will govern the registries. The data will be entered, and you will be asked to enter the data, and the data will be entered, that will be entered is divided into 2 parts. One is common to all registries, obviously demographics, comorbidities, etc. And the other is disease-related variables. Now, who will enter the data? Obviously, the physician in charge of the patient will enter the data, or his, designee will enter the data under a specific code directly into the registry program. It's a program online. Of course, you can ask for help from us to enter the data, and we'll provide you with the necessary help, especially at the beginning, to enter the data and to navigate through the system. We will ask you to create a patient-specific code that will allow us to for 2 things. This patient-specific code will take this form. It will have the initial letter of the patient name, first name, father name, and last name, followed by his date of birth as day, month, year, attached together. For example, if someone is named, let's say my name is Imad Joseph Ba'al, I will be IJB, and then the date will be entered all together. If the day will be 07, because I'm 7, I don't want to give my birthday. But let's say on the 7th, and then any other that has a 0 will add a 0, and then a 4-number year. So why have a specific code? Well, this code, if you read it, you cannot tell who's the patient. But if you know the patient and you enter it, you can tell. So this will allow the physician to, once, we want to follow up. What happened to this patient? Did you do any new studies? We'll send you a reminder to follow ahead. You can, because you are the person as a physician who entered the data. You can go in, you put, you have your patient, you put the code, and you know him, because this is a unique code by the name that you cannot go and guess who's the patient is. And also, it will allow us to prevent, duplication. Maybe the patient is seeing 2 physicians and he's not telling them, and both of them enter his data. Then we will recognize, and then we will contact one to tell him that the patient is being seen by someone else, and we'll see who has the more complete data, and we'll follow his guidance. Of course, a steering committee of the LPS is responsible for the creation of the registry and is working on this currently, and will be responsible in the future for the safety of the data and the management of the data. It will follow specific rules set by the laws and related to the NAEBI of the physicians. It is formed of members of the society, along with members from the cardiology society, because we want also involvement of cardiologists with us. As you know, PAH is, with other diseases, involved with other diseases. It also includes pediatric pulmonologists. A specialized software will be created by Science Pro, respecting the rules and regulation governing the data. Of course, I would like to always remind people about this. It will look like the COVID-19 registry. If you have started using it or not, maybe it just went online, it will look like this. So what you will have is a scroll down. Sometimes you have to enter the data. Sometimes you have just to click and choose something. This is an example. This is obviously from the Science Pro Lebanese National COVID-19. It's the same software, but obviously different variables. And this is more longitudinal. Hopefully we will get rid of COVID. I don't know, maybe it will run as long as the others, but hopefully not. Other data will be entered. And as much as we can, we're going to make the data clickable, even, the questions related to if you have finding on CT scan, what did you have? You have epicobasal predominance of infiltrate, upper lobe, lower lobe. You just click. You don't have to enter them. You have lymphadenopathy, hilar, mediastinal. So we'll make it as easy as possible for you to enter the data. Same for the nomographics. So instead of everyone will put a name, let's say I'm from Limtain or some other small village, and we won't know what to do with it. What we'll ask is a cluster of villages under Qada, and we'll give you the choice, and you choose the closest possible. Asbaya, Batroun, Psherri, Zgharta, Tripoli. So we'll give you the option. And in the software, this is obviously the variables, not the software. All you have to do is click. Now, those are the members of the steering committee in alphabetical order, and more are and will be joining. But once they join, we will inform you of their names. Maybe they will refuse or they change their mind. So we rely on your collaboration. Obviously, creating registries for us as a society and us as a profession of pulmonary or as physicians, these registries will be extremely important. They will give us an understanding about our disease in Lebanon. Hopefully, we will be able to provide meaningful data for guidance for us physicians. But this to succeed, we'll need your collaboration. We are going to provide you with the help needed for the work, but we still need your initiative. Thank you, and stay tuned